Good evening and welcome. My name is Gary Morrison and I'm a part of the management committee of the LGBTQIA+ Shine a Light group based in Sydney, Australia. I'd like to welcome you to our 2023 webinar series. Before I do go any further, I'd like to do a welcome to country. I would like to acknowledge the traditional custodians of the Aurora Nation that I am speaking to you from this evening. I also acknowledge the traditional custodians of the lands on which each of you are living. As we share our knowledge, may we also pay respect to the elders, both past and present, as it is their knowledge and their experiences that holds the key to the success of future generations. Thank you very much. As I said, I'd like to welcome you all to our 2023 webinar series. Back in 2022, we were very fortunate that our major supporter, Boston Scientific, supported us in bringing to you a 5-part webinar series. It was hugely successful, and we've been fortunate again to get their support to be able to bring to you another 5-part series this year. I'd like to particularly also say thank you to PCFA for their support. They've been a part of our support group for well over 14 years, and their ongoing support in the prostate cancer area is hugely welcome, and we thank them for their support again this year. Tonight's webinar is supportive care and what it means. Within our support group, there are a number of members who were wanting to get a better understanding of what supportive care is, and also what a multidisciplinary team is. And we're very fortunate tonight to have 6 very, very good speakers led by Cynthia Parr. And I'd like to welcome them all, and I'll leave it to Kalli Spencer, who's my co-chair, to be able to do the formal introductions.
Thank you, Gary. There's many myths around supportive care, palliative care and hospice, and it's probably not something we want to think about, but actually it's something we need to think about. Many don't know that we don't only have to access the service at the end of a cancer journey. There's a whole range of support services available, which we are about to hear about, that can be accessed the minute you get the diagnosis of advanced cancer. That's right, any advanced cancer diagnosis. And once you have used the service, you can even be discharged from the service. And the services are free. So keep listening. Dr. Cynthia Parr and I got chatting at a social mixer, as one does. I said, "What do you do?" She said, "I'm a palliative care physician." And she said, "What do you do?" I said, "I'm a urologist. But I also run cancer support groups." And this sparked a conversation. And I shared that this need came up for information about these services by the participants within our group. And there's always a concern once you've had prostate cancer treatment that it may return. And for those where it has returned, they want to know, well, how's it going to be treated? And those that are being treated, there's always in the back of their mind, what happens if the treatment doesn't work and what I need to consider next? So it raises many questions. And so this led us to this novel idea. And Cynthia swiftly organized this panel of very experienced speakers that form part of a multidisciplinary team working in this space every day. So I'd like to introduce Dr. Cynthia Parr, who will start off tonight's discussion, and then I'll subsequently introduce the other 5 speakers as they're about to start presenting. And in this way, we'll get a good idea of what everybody in the team actually does. I'd also like to remind everyone that there is a place to ask questions, and we encourage you to continuously ask questions as we go. Your questions are anonymous, and where relevant, I will address the questions to each of the speakers after they've spoken. And if you remember something as we go, we have a Q&A session at the end, so you can ask any further questions you have. So please stay till the end so we can ensure all your questions will be answered. So Cynthia Parr is a palliative care physician with over 20 years of experience in consultant practice, with clinical appointments at Macquarie University Hospital in Sydney, as well as Hornsby Ku-ring-gai Hospital in the Northern Sydney Local Health District. She gained a medical degree from UNSW and completed her palliative and supportive care training at the Royal North Shore Hospital and with Hammond Care Palliative Care Services. And this embraces both inpatient and community settings. Cynthia is a clinical lecturer at the University of Sydney, Northern Clinical School, and also at Macquarie University Faculty of Medicine, Health and Human Sciences. With an interest in education, Cynthia teaches medical students and she supervises palliative care advanced trainees, so those that are specializing to become palliative care physicians through the Royal Australian College of Physicians. She's also a member of the Palliative Care Clinical Studies Collaborative and the Australian New Zealand Society of Palliative Medicine. So we really are privileged to have you here tonight, Cynthia, and we look forward to hear what you have to say.
Well, thank you so much, Kalli, and good evening, everyone. Firstly, on behalf of the team, I would like to thank the Shine a Light group for welcoming us tonight and giving us the opportunity to speak to you about supportive and palliative care. As we are talking of prostates and all things urological tonight, I thought it was very fitting to begin with a slide of Dr. Balfour Mount. And so who is Dr. Balfour Mount? Well, he's a very famous Canadian urologist, but he is mostly known for his work in palliative care, and he's credited for being the founding father of palliative care in Northern America. And he is based at McGill University in Montreal. And at the beginning of his career, he specialized in urological cancer surgery. But the direction of his life took a turn in 1973 when he went to a lecture and he heard this psychiatrist named Elizabeth Kubler-Ross speak about caring for people with life-limiting illnesses. And he was quite struck with her presence and with this philosophy that she had of what she called whole person care, which was the idea that suffering encompasses all of a person's psychological, social and spiritual struggles rather than just in the physical aspects of their disease. And through Elizabeth Kubler-Ross and further learnings, he became aware of Dame Cicely Saunders and St. Christopher's Hospice in London. Now, Dame Cicely Saunders was a very influential figure in the 20th century. And through her, she transformed the way the world viewed and treated people with life-limiting illnesses. And she introduced effective pain medication. She had a focus on research and teaching. And she founded St. Christopher's Hospice in 1967, which was the first international and credible center which cared for people with life-limiting illnesses and cared for the dying. And she too worked on developing this notion of whole person care. And so Balfour Mount met Cicely Saunders at St. Christopher's Hospice. He spent 1 week there and he was very impressed with the quality of his care, so that when he went back to Canada, he also set up a very similar model, except it was set in an academic center in a faculty of medicine. And he was very excited with this new model of care and felt that it needed a new name. And so it actually was Balfour Mount who coined the term palliative care, because palliative care means to alleviate. And the Latin root of the word is pallium, which means to cloak or to shield. And this palliative care movement over the years took momentum and spread to Australia, to the United States. And at this point in time, palliative care is a very integral part of care in many healthcare settings. And by 1990, the World Health Organization recognized palliative care to be a distinct specialty of its own. And the current definition of palliative care is that it is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illness. Palliative care prevents and relieves suffering through the early identification, correct assessment and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Now, palliative care is very effective. And in the last decade or so, many robust studies have shown that if you integrate palliative care with standard cancer care, that there are lots and lots of benefits for people with cancer, including significantly improved quality of life, physical and spiritual well-being, improved patient and caregiver satisfaction, less unnecessary hospital admissions, and less aggressive treatments at the end of life. And if you're a health economist, it is important for you to know that early referral to palliative care also leads to lower health costs. Now, prostate cancer is particularly amenable to palliative care because of its long disease course and often non-lethal progressive nature. And the limited studies that we have on palliative care in prostate cancer reflect the previous studies, where we show benefits in terms of improvement in symptom control, particularly with fatigue and pain, with sleep, anxiety, and depression, and overall, just an overall improvement in quality of life and spiritual well-being. So really, we've got all these benefits, but the thing is, what really happens in the real world is that referrals to palliative care in prostate cancer and other cancer settings are really made very late in the course of the disease. And possibly this could be related to this misperception that palliative care really is only about the end of life. It is a myth that you have to stop all active treatment when you are referred to palliative care. And it is a myth that palliative care is just for the last few days of your life. And, you know, there is really a failure to recognize that there's so much more about palliative care, and that we also do a lot of symptom control. And it's not unusual, you know, very occasionally when people are referred, well, I'm asked to see someone, that they would say, oh, whatever you do, don't say the word palliative, or in fact, just don't say the P word. So there were all this almost this stigma with the word palliative care. And so more recently, the term supportive care has gained popularity, and it arose specifically to refer to care directed at managing the symptoms of or adverse effects of cancer and cancer treatments. And there are very many definitions of supportive care, but the one that I have up here highlights early referral or early involvement of palliative care services. So supportive care can be defined as the prevention and management of physical and psychological symptoms and side effects across the continuum of the cancer experience, from diagnosis through anti-cancer treatment to post-treatment care, and enhancing rehabilitation, secondary cancer prevention, survivorship, and end-of-life care are all integral to supportive care. And so there's been a slight shift in terminology, and many organizations have now renamed themselves or rebranded themselves, if you like, and instead of calling themselves palliative care services, they call themselves palliative and supportive care services. And you will see this on their websites, in journals, and in books. And sometimes the terms are used interchangeably, and at other times services just call themselves supportive care services and drop the palliative. But what this alludes to is that we do more than just end-of-life care, which we also do very well. Now, Palliative Care Australia is the peak national body of palliative care. And recently they ran a campaign called Palliative Care, It's More Than You Think, to try and dispel this myth that palliative care was synonymous with just end-of-life care. And so you know, if you look up their site, you'll see all these brochures and cartoons and videos to try to get this message across. So now let's look at who provides supportive and palliative care. So supportive and palliative care really is the responsibility of many clinicians and many disciplines. And early in the course of the disease, urologists and medical and radiation oncologists manage the symptoms of cancer and side effects from treatment, and if necessary, make referrals to other services such as sexual functioning rehabilitation or incontinence care. And general practitioners also have a very good knowledge of basic symptom control and end-of-life care. But a specialist supportive and palliative care service can be contacted if the needs of the patient are complex, if they've got complex needs and the other clinicians need assistance. And supportive and palliative care teams can see patients episodically, as Kalli alluded to, sort of like dipping in and dipping out of the service, depending on the needs. And if needs are complex and conditions unstable, and if people require ongoing care, supportive and palliative care teams can provide that as well in partnership with general practitioners and other medical health professionals. Now, let's look at what matters to people with advanced cancer. And there certainly have been a few studies that have tried to delve into these issues, and the results show some common themes shared across the studies. People with advanced cancer want to have a doctor that they can trust, and they want to receive information in a timely fashion, to have effective communication and shared decision making, and they want to have respectful and compassionate care. People also want to be free from pain and other physical symptoms. They want to have their family present, and they want to enable their family to be involved in their care. And also dignity and maintaining meaning and identity and a degree of independence was deemed a priority. And last but not least, spiritual issues or anything pertaining to their spiritual beliefs was also seen as very important. And now let's look at what matters to the families of people with advanced cancer. So what are the challenges for families and caregivers of people with advanced cancer? Well, there are lots of challenges. Firstly, relatives and families have to emotionally come to terms with the disease. And on top of this, they've got to do all the practical stuff as well. They've got to do the personal care, the cooking, the cleaning, the shopping, driving to take their loved ones to medical appointments, giving medications, changing catheters, dressing wounds and coordinating everything. And there could be a disturbance of social routines as well, and financial burden if people find that they would have to give up work to look after their loved ones, and diminished leisure times. And so there is a predisposition for families and caregivers to health problems, particularly with exhaustion and burnout. And when I say families, there are biological families, but there are also chosen families and caregivers, people who you would choose to care for yourself. And so I guess in a nutshell, if we want to meet the needs of people with advanced cancer and support their families, then we have to tackle all the dimensions of suffering. And what you do need to tackle the multidimensional nature of suffering is a multidisciplinary team. And palliative care teams are uniquely multidisciplinary and typically involve in each team specialist palliative care nurses, doctors, social workers, physiotherapists, occupational therapists, and pastoral care workers. And many palliative and supportive care teams have got volunteer services attached to them as well. And so what are our roles? So palliative and supportive care physicians, we control and manage symptoms. And these include the common symptoms of pain, shortness of breath, constipation, fatigue, insomnia, and any other symptom that that a patient may have. And we work very closely with general practitioners and oncologists and any other health professionals to achieve good symptom control, and we coordinate our care. And the other thing that we do is we assist with decision making for the future and advanced care planning. Our palliative and supportive care nurses and nurse practitioners. So a nurse practitioner is a very highly trained nurse, fairly independent, and they can prescribe medication and they can make referrals to other health services as well. So the nurses tend to coordinate the team, and they look at what the needs of the people are, and they decide who goes out first. And they work very closely with other community services. And they assist physicians managing pain and other symptoms with medicines and practical strategies. As social workers, they provide information for matters legal, financial, or practical, and also link you to other services that you may be entitled to help you with these matters. They are trained counselors and provide emotional support, which complements our treatment when we manage anxiety and depression. And they also discuss ways of coping, and they support families and children, and also teach about how to talk to children. Our occupational therapists just help manage with the day-to-day aspects of living, and they advise on physical aids to improve mobility. They organize the equipment or hire of equipment, or advice on home modifications, and they assist with energy conservation. Our physiotherapists help to keep people moving and functioning, and actually use their physical strategies to help with symptom control, symptoms such as pain or shortness of breath, and also show patients how to exercise within what is reasonable for them to increase mobility and energy. Our pastoral care workers support patients and families to deal with spiritual matters and connect patients with other members of their own faith, whatever that faith or belief system may be. And some are trained counselors and can discuss emotional issues as well. Now, volunteers are very important people, and we train and screen our volunteers, and they do provide practical assistance and provide companionship, which is very important if you're wanting to sort of manage loneliness or social isolation. And so I guess the model of care that we have in palliative supportive care is that of the person with their many, many needs at the center, surrounded by their families and protected by the palliative and supportive care multidisciplinary team, acting like that shield or that cloak that Balfour Mount envisioned. So to summarize, what help can you get from a supportive and palliative care team? You can get help with symptom management, help with planning future medical treatment decisions, getting equipment to aid care at home, family assistance, links to other services and financial support, counseling and grief support, and bereavement support. Where can you receive supportive and palliative care? So you can get this in an acute hospital. If you are an inpatient, they have palliative care teams within the hospital, or it could be that you will be seeing palliative care teams in an outpatient setting, like in a clinic. Palliative care units, these are hospitals, but they are smaller hospitals. They are not really all that acute. They still do simple medical treatments, but the focus of care really is on symptom control and comfort care. Supportive and palliative care at home and in the community, you do have the community teams who can come and visit you at home, together with other community services, and working very closely with general practitioners and other health professionals. And in residential aged care facilities, in nursing homes, what we're finding is that more and more nurses or nurse practitioners are going into these facilities to support the nurses and the general practitioners on the ground with symptom control and end-of-life care. So how can you be referred to supportive and palliative care services? Well, you will need to have a medical referral from your general practitioner or any other medical health professional. And you will be referred to the service that is closest to where you live. So your postcode really decides which community palliative and supportive care service you are linked to. Palliative Care Australia have got this little directory. So if you go onto the website and follow the prompts, you can type in your postcode and up will pop the services that are closest to where you live and all their contact numbers, so that you can make contact with them with your referral from your GP or oncologist. Now, how much will being linked to a community palliative and supportive care service cost you? So I think state, federal and territory governments fund a range of palliative care services which are free. So Medicare will cover the costs of palliative care and supportive care. But I do know that certain private insurers will cover extra costs. For example, if you need to hire specialized equipment, or if you need certain medications, or if you had to pay the fee of a private health practitioner like a clinical psychologist or private nursing. So we've talked a little bit about who we are and how you can get to know us and broadly what we do. So we're going to talk a little bit more in depth of some of the things we do, starting with advanced care planning. And this is very important. And advanced care planning is really decision making for the future. And an advanced care directive is really a way of saying what healthcare treatments you would like or not like should you be in a position where you're not really able to communicate your decisions about your care. And it's just very important because if a crisis were to happen in the future, your family or your doctor may not know what to do or what would have mattered to you. And an advanced care directive will help them make decisions that they know that you would have wanted or felt important to yourself. And the first step with advanced care planning is really thinking about what is it that is important to you. And there are advanced care directives, some forms, and up here I've got the New South Wales Health Advanced Care Directive. And it just is, it acts a little bit like a prompt to raise issues that are important and could make you think. And issues like, who do I want to make decisions for me if I am unable to make decisions for myself? Or what is important to me and what are my beliefs and values and how do these impact on what care I would want in the future? Or where do I want to be cared for at the end of my life? What medical treatments would I want to have if I am not expected to recover? And this could include discussions on ceilings of treatment, including cardiopulmonary resuscitation. So the first step really is to have a think about all these issues, to go through the forms. And then the second step is to talk to your families and your friends and your doctors so that you can discuss these issues with them more fully and complete the form. Now, for the rest of the session, my team and I will be talking about some of the more common symptoms that people with advanced prostate cancer do encounter and the ways that we overcome them. And we're going to begin with pain. So pain is a very personal experience and it's really different from everyone. And there's a lot of things, a lot of factors which contribute to the experience of pain. And likewise, pain will also have an impact on psychological well-being and also on your functioning. And specialist supportive and palliative care teams are trained to do very comprehensive pain assessments and to try to elicit what is the cause of the pain. So we have a lot of tools to try and work out, where is the site of the pain, how severe is it, does it come and go, what makes it better, what makes it worse, what is the quality of the pain, what does the pain mean for you, and how does it impact on your function. And we do a very comprehensive assessment and we try to look for a cause of pain. And when we think we have a cause, we try to remove that cause or we treat whatever is reversible. But if we cannot remove the cause of the pain, what we can do is remove the perception of the pain with a lot of different treatments using pain medication. So pain medications, and there are lots of them. They can be as simple as medications that you get over the counter, drugs like paracetamol or non-steroidal anti-inflammatory drugs. And if pain becomes stronger, a strong opioid such as morphine or fentanyl or oxycodone. And then we also have what we call the adjuvant analgesic agents. And these are medications that really, their primary indication is for something else, but they do have an effect for pain relief. For example, drugs used, antidepressants and anti-epileptic drugs can be used to manage nerve pain. Anti-anxiety drugs can be used to alleviate muscle spasm. And steroids we can use to remove inflammation. And what we do is we use the right combination of drugs and we individualize treatments so that we can find a regime that works for our patients. And the other thing we do is we do educate our patients on the cause of their pain, the treatments they're on, the side effects, and also we take away all these myths and misperceptions that they may have about opioids. A lot of people are worried that, that they would become drug addicts or that if they use a drug early in the course of the disease, it would lose its effect later down the track. So we correct all these misperceptions and we kind of tailor the drugs and we monitor pain regularly, response to these medications regularly. Now, for people with prostate cancer, where the disease is spread to bone, and also for people with prostate cancer who are on hormonal therapies, it could be that they would experience bony pain. And there are bone protecting medications which decrease bone loss and decrease breakdown, and these can be used to help with managing pain and trying to prevent skeletal events down the track. And these include drugs such as the bisphosphonates, zoledronic acid, and primidronate, which can be given intravenously. And there's also a drug called denosumab, which can be given under the skin subcutaneously and can be given in an outpatient clinic or also in a GP surgery. Now, radiotherapy is very powerful. It's very effective in managing pain from bony metastases. And the majority of patients who receive radiotherapy for bony pain do respond to the radiotherapy, sometimes to the point where we have to cut back on the pain medications. And importantly, even one treatment, even a single fraction, can be very effective in treating pain. This is external beam radiotherapy, can be very effective in treating pain. And incidentally, radiotherapy is also very effective in treating symptoms such as bleeding. Now, if the bony secondary is pressing on the spinal cord and causing a cord compression, spinal cord compression, or if a bony secondary is pressing on a nerve root, radiotherapy can also be used on an urgent basis to minimize the damage and to preserve neurological function, and also can be used as an adjunct with surgical management and in combination with steroids. So radiotherapy is very effective. And also, I'm pleased to say that there are advances in the delivery of radiotherapy in certain centers. You can receive simulation CT-free radiotherapy for the palliation of pain from bony metastases. You could just be transferred to the unit and sign a consent form and have the treatment in an hour or so. And sometimes, you can get treatment within 24 to 48 hours. So this is very positive. Now, for the minority of people who have got severe pain, that's trickier to manage, and this is very much a minority. We collaborate with our colleagues with acute pain services. These are anesthetists, and we can rely on procedural interventions to manage pain using nerve blocks or epidurals or device implantations. And so there's medication in the device, and it is delivered through these devices, and we usually get on top of pain. Other approaches for managing pain include physiotherapy and occupational therapy, and we also try to deal with matters that, I guess, psychological issues that impact on the perception of pain, and clinical psychologists can help us with methods such as relaxation, distraction, or cognitive behavioral therapy to deal with whatever it is that's contributing to the pain. Complementary therapies for cancer pain. Now, these may help you to cope with pain and decrease your anxiety, and I've listed quite a few on the list, such as massage and relaxation, heat and ice therapies. I guess as a general rule for complementary therapies, it is just very useful to let your doctors know what therapies that you are using, as it is for you to let your complementary therapists know about your cancer and about the sites affected. And so we have lots of strategies in dealing with pain management, and we move now to shortness of breath. Now, shortness of breath may be caused by the cancer itself. It may be caused by infection, by cancer treatments, or maybe there's another underlying disorder such as emphysema. And as with pain, what we do is we try and find out what the cause of the shortness of breath is, and if it is reversible, we treat it. And if appropriate, we do treat it. However, in some people, they will still have the chronic breathlessness despite trying to treat the cause of the shortness of breath. And the measures that we use to try and deal with this include, depending on the cause, using a low dose morphine. So what we would use is oral morphine, and it would be a sustained release morphine, a tablet that works over 24 hours or so. And the studies do support the use of morphine for chronic breathlessness. And studies also show that morphine is effective and it's well tolerated and also very safe. Now, oxygen is something that is widely used, but I guess the best thing to say about it is be guided by your doctors as to whether or not oxygen is something that will be useful. If you are short of breath, it works mostly for people whose levels of oxygen in the blood are low. And there are other interventions for shortness of breath, which physiotherapist Sally Baksa will talk to you about. But I'm just going to finish up with this slide on exercise, on fatigue and exercise. And the Prostate Cancer Foundation have got a fact sheet on prostate cancer and exercise, and also a webinar and I think videos to talk about exercise, because it's really very important. Exercise is so good for you. It reduces fatigue, it helps with anxiety and depression, and it also maintains your function during and after treatment, and reduces the risk of cancer recurrence and developing other chronic diseases, and you just get a better overall survival. So I will leave you with some resources, some links to the Palliative Care Australia website, including the directory, and also some sites that will help with advanced care planning. And I've also put Care Search up there, and Care Search is like a knowledge network where you can find evidence-based information on all things palliative and supportive care related, including medications and symptom management. And so, Kalli, I'm just going to hand back over to you to introduce the next speaker.
Cynthia, thank you so much. That was so informative, and it's just amazing to hear how many resources and services are available for patients with advanced cancer. The audience has been very quiet. I just wanted to remind them that there's a dark blue hand button up on the right side of your screen, and you click on that, and that's where you'll ask questions. So please type your questions in the chat there. And I'll be able to direct it to the speakers. Anything you want to ask about supportive care and palliative care. So thank you, Cynthia. And let's move on to our next speaker, Sally. Sally's an accomplished senior physiotherapist with over 10 years of experience working in the palliative and supportive care team at Hammond Care. Her commitment to improving function, managing symptoms, and providing quality holistic care is evident in the work she performs with her patients. Sally has expertise in breathlessness management and has been instrumental in establishing a breathlessness program to assist those with the symptom. So over to you, Sally.
Thank you, Kalli. And thank you very much for having me this evening. I am really pleased to be here to be able to present to you on the physiotherapy, some of the things physiotherapy can do for palliative and supportive care. I'm going to go through some information on exercise, and then I'm going to go through some information on breathlessness management. So exercise benefits, and Cynthia's already gone through a few of these, but I just want to outline why you want to keep exercising, or why you want to maybe start exercising. Exercising for everybody is sometimes a little bit of a chore, and we all need some encouragement. And hopefully I'm going to give you some reasons why you should keep or start or think about exercising, especially when there's a temptation to rest, maybe at diagnosis or throughout treatment, or if you're post-treatment. You tend to protect yourself and then tend to move towards more restful behaviour, and that's not great for you for a number of reasons. I also want to just refer back to Professor Robert Newton, who did present and is available to be watched on a webinar. He presented about 10 months ago, where he explains in detail the benefits of exercise, and really is a very good presentation. So if you want more detail, I think that's a great place to go. He's really clear in his message of exercise being seen as a medicine, both pre, during, and post therapy. From a supportive care point of view, it's much easier to maintain your strength than to have to work to regain it. Your quality of life directly correlates to your physical function. So for exercise, there's lots of reasons why too. So overall health, exercise will help your overall health. It's really important to look after your whole body. Also, cardiovascular disease is a major survival concern with those on androgen deprivation therapy. Aerobic fitness will assist in maintaining a healthy cardiovascular system. And it's also been shown to minimise PSA rise. Mood and well-being, really, really good for your mood. And this is something that we all want. So exercise will make you feel better. It improves your resilience and will aid in your ability to manage your symptoms. Another really important factor is it does give you some control over your health. So you're actively participating in your own care and you do have a little bit of control over this. You can choose how you exercise, what you do, when you do it. And it is such a positive part of managing your health and your well-being. Energy levels, a little bit counterintuitive, but believe me, it's the best thing you can do for fatigue. It may need to be managed and you may need to pace yourself depending on your levels of fatigue, but it is one of the best things you can do by starting some support and some exercise that is being maybe managed by a health professional will help with your fatigue and your levels of energy. It is essential in maintaining your muscle and bone strength. So what you want to do is you want to maintain function, and this is really important for independence. So you can be as active as possible for as long as possible. Muscle mass is a critical player in well-being and overall survival. And bone strength is really important, especially if you have any metastases. Improved treatment outcomes. Exercise has been shown to reduce treatment side effects. You're much more likely to be able to manage treatment doses and therefore stay on higher levels. And it's also been shown to improve chemotherapy and radiotherapy effectiveness. It improves your immune function and, really importantly, social support. So you might be exercising with a friend, with family, or you might be a part of a group, all really important as it improves your emotional well-being and your overall quality of life. So what are the recommendations? Very briefly, basically try and do everything. So a mixture of aerobic and resistance is really what you want to go for. Aerobic, as we've talked about, is for your cardiovascular fitness. Resistance will help specifically with your muscles and your bones. So having a mix of aerobic and resistance is ideal, but if you've only got so much time and energy, you might want to choose what is most in need for you, for where you are in, and what you need for the maximum well-being and for what you need to get out of the exercises. I also like to include balance because we do work a lot on falls prevention, and that's really important. So if you can add some balance exercises in there as well. Resistance exercises should be dynamic in nature and really think about doing functional exercise. I really am quite an advocate for functional exercise. So everyone who comes into contact with me generally sits to stands as one of their exercises. It's good for falls prevention. It works lots of systems and it's gets your heart rate up, gets your breathing up, and it works a lot of muscles. So aerobic work, there's a Borg, a scale of perceived exertion. So we get you to rate how you're feeling with your exercise, and we tend to get you to work between 11 and 14 out of a 20-point scale. So that's working quite hard, short, maybe being able to speak in short sentences, sweating a little bit, but pushing hard enough to get a good effect from the exercise. Pelvic floor exercises are important for everybody, and there's a couple of ways to do it, and you may need some guidance on this, but there's fast twitch and there's also the slow and sustained exercises you can be doing. Ideally every day, and even better a few times during the day. The more you do them, the better your pelvic floor is, and the more control you have. How often you need to be exercising. Once again, ideally regularly, much better to be spacing it out through the week rather than trying to do a big chunk on any given day. If you can, 3 to 5 times a week, or even smaller sessions every day, depending on what works for you, and aiming for around 20 minutes a session. But once again, whatever suits you, something is a start and anything is better than nothing. So if 5 minutes is all that you can manage at the moment, 5 minutes is great. And maybe in another week or so, you build that up to 10. Just starting somewhere is really the aim of the game. Making your exercise meaningful. So going back once again to functional things. So being able to get up off chairs, beds, getting out of cars, maybe being able to walk to the local coffee shop, getting up and down your stairs, whatever it might be. Try and incorporate something that means something to you, just because you're much more likely to keep on doing it if that's the case. And finally, flexible. Be aware of your progression. Progression might be slower. It might be different for every person. It might be dependent on how you're going. If you're having treatment, you may have to work around your treatment. Although, as I've said earlier, exercise has been shown to really help with how you manage if you're on treatment. But you might have days that you're feeling a little bit more flat. They're the days to maintain what you've got. And the days that you're feeling like you have that little bit more to give, push a little bit harder and gain on those days. And really important that it's enjoyable, because if it's not enjoyable, even though, as I said, it is a form of medicine, and sometimes medicine's not always pleasant, and you need to just have that mindset that you're going to get it done. If it's enjoyable, you're much more likely to be happy and willing to do it. All right, moving on to breathlessness. And Cynthia's already touched on some of the things we do for breathlessness, but I thought I would go through what the components of breathlessness are, just so you can understand why you might be feeling breathless. So there's 4 main components. You've got air hunger, and that's coming from your chemoreceptors, and that's your oxygen levels and your carbon dioxide levels. You've also got information going to your brain about how hard you're working, so how hard your muscles are working and how much work or effort you're putting into breathing. You might have chest tightness, and that is where the smooth muscles around your breathing tubes get tighter, and then you feel that difficulty getting the air in and out. And you've got non-sensory factors, which are your emotion and your attention. And that comes down to past experiences and how you're perceiving your breathlessness. And this is something we can make quite a difference with, changing how you perceive your breathing. I thought I'd put this slide in just to show you that breathlessness or dyspnea is made up of a number of different factors. So I've talked a bit, and it's probably quite easy to think about the physical factors. So especially with therapy and fatigue, and if you have a cancer diagnosis, or if you have non-cancer diagnosis, so you might have underlying condition that is separate to your cancer diagnosis. There's also the psychological information that's going into your perception of your breathing, and that's that fear of breathlessness, and that fear and maybe feeling a bit down about how the breathlessness is controlling what you can and can't do. Social aspects play in. So people who become breathless tend to start to self-isolate because getting out becomes more difficult. And the more people isolate from social situations, the more their breathlessness becomes a bigger part in their life, and the more it plays into how they perceive it. There's also the spiritual aspect, and quite commonly feeling like, why me? Why is this happening to me? That also plays into how you are perceiving your breathing. This is the model that we use, which is an excellent model developed by Sarah Booth and for the Cambridge Intervention Service, and shows you the 3 areas that we really look at when we look at managing breathlessness. So we've got the breathing, and that's the way you're actually breathing. So it's how you might be breathing shallowly, you might be breathing quite quickly, you might have an increased work of breathing. And when we look at that, we look at teaching breathing control mechanisms and methods, and maybe using a fan on your face and working on specifically how you're breathing. Then, as I said, because of where you're perceiving your breathlessness, so it's going to the center where you have the fight or flight reaction, so the corticolimbic area of your brain. And this area gets information from your memories and your past experiences. So anxiety, which is very common with breathlessness, and it's hardwired into us that when we get breathless, it is an anxiety provoking sensation. So it's a very normal response to being breathless, is to feel these feelings of anxiety or distress or panic. And this is something that we can help you deal with. We do this through anxiety management. We also address any concerns that people have. So sometimes these concerns are abstract, and we can give information and strategies on how to manage and make you feel more in control. And relaxation and mindfulness is helpful as well. Then the functioning cycle is the last one that we look at, and that is actually looking at reduced activity. So coming back to exercise being another great thing to be able to do. Pacing activities. We do look at walking aids, and that is to help with positioning, as well as accessory muscle use to help you have more muscles to help you breathe. And we look at just deconditioning and what we can do to help with that. This is the scale we use to measure your breathlessness, and it's a subjective scale. So this is something that you're telling us. It's not how we think you're breathing, it's how you're feeling about your breathing, because everyone's perception of their breathlessness is different. So hopefully at rest, you're in the blue section somewhere if you are breathless. And then as you started to perform activity, exercise, general activity, whatever it may be, you move down the scale. And we recommend, if you can, if it's not an emergency, that you stop at 4, which is somewhat severe. So it means you're breathing up, you're working quite hard, you're getting the effects of the exercise of what you're trying to do, but you're not pushing down into those areas where you feel like it's getting out of control and you're going to have really negative, unpleasant feelings. And building on what I was speaking about earlier is that the more negative feelings or memories you have, the more your brain's going to protect you and say, oh, avoid that, don't do it, just sit down, try and avoid it. By pushing to a 4, you get enough of an exercise effect without those feelings of the breathlessness getting out of control. And when you get to a 4, this is what we recommend. So getting into a comfortable position, and that is generally, for most people, it's a lean forward position with your arms supported, like a marathon runner at the end of a marathon race. Leaning forward offloads the diaphragm. Having your arms supported allows these extra muscles around your neck and your shoulders, called accessory muscles, to help lift and lower your rib cage, which gives you more oomph to get your breath back under control. So you've got more muscles working for you. And while you're actively breathless, that's a really good position to be in, so those muscles can work to help you breathe. The second point is slowing your breath down, which may be very difficult, especially when you're feeling like it's out of control. You can do this by focusing on the exhale. The area of the brain that will be stimulated will be telling you to focus on the inhale. But if you do that, you tend to breathe at the top of your chest, and the carbon dioxide and the waste products are still sitting down the lower parts of your lungs. So what you want to do is slow your breath down, focus on the exhale. If you can use pursed lips, you breathe out long and slow through pursed lips. If you're able to, in through your nose, that also slows the breath down. Pursed lips splints gives you some positive pressure in your airways and splints them open for just that little bit longer, giving you more time to get the air out. And sometimes it's like thinking of smell the roses, cool the soup, or counting, or finding a rectangle and working around the rectangle. The longer part of the rectangle is your exhale, the short part is your inhale. Third point is using a fan on your face. Very, very helpful, very good trick of the trade. You've got trigeminal nerve receptors around your nose and your mouth. By stimulating those with moving air, that sends messages back to your brain saying you're not as breathless as you think you are. So if you're out somewhere and you can get some cross ventilation, if you're in the car, you might turn the aircon on your face or open the window, or there are little fans that you can buy at a number of places that you can just have in your bag, pull it out, and pop it over your nose and your mouth, and that will give you instant relief from that feeling of breathlessness. And as Cynthia mentioned, medication, there are medications that are used, and that's something to discuss with your doctor. It needs to be prescribed. But really, if I can give you one takeaway, is that confidence is key. So feeling that you know what to do when you get breathless is the biggest part of getting your breath back under control. Breathlessness will not kill you. It does feel like when it's really bad that it will get out of control. Knowing what to do, having a few steps and feeling confident that you can get it back will make all the difference in how you feel about managing your breathing, and therefore give you confidence to be more active and do more, which then in turn will make you feel better. And I've also got some resources, quite a few on breathlessness management, because that is my area of expertise. There's some education and information, some general information from the Hammond Care Palliative Care Bridge and Hammond Care. I've got some information from the Cambridge Breathlessness Intervention Service. It's got some excellent things to watch and handouts in that. There's a podcast if you enjoy listening to information, maybe when you're going for a walk. And there's some programs that you can access in Australia. There's the Lung Foundation for Pulmonary Rehab, and they also have Lungs in Action for when you've finished a course. And I run a breathlessness program, which is run at Hammond Care for the North Sydney Local Area Health District. And I will pass it back to Kalli and to the following speakers.
Thank you very much, Sally. That was great and very interesting to see, what options are available for people that are having breathlessness. If anyone needs access to these resources, you are welcome to, contact us after this webinar, and we'll gladly link you up and give you them. There was a question that came through in the chat for you, Sally, about any recommendations for pelvic floor exercise resources. I know that's not your particular area of expertise or interest, but do you happen to know any?
Not specifically. I think it's probably best to find a pelvic floor physio specialist that can then really guide you well and do an assessment and work out the specific exercises that are going to work best for you.
Yeah, it is quite a specialized area of physio, isn't it?
It is.
Yeah. Well, that's great. Thanks, Sally. Just so it seems like some of you have figured out how to ask the questions, but just a reminder, it seems like you need to minimize your screen from full screen, and then the dark blue hand appears up in the right side of your top part of your screen, and you click on that and you'll be able to chat and send us your questions. So keep them coming. But for now, I'm going to hand you over to the next speaker, who is Marlene. And Marlene is an occupational therapist with over 30 years of clinical experience. For the past decade, Marlene has been working in supportive and palliative care. Her role was involved helping to optimize independence in activities of daily living, assisting with setup of the home, and offering education to patients and their families on techniques for optimizing function and management of symptoms. Marlene is a strong believer in a multidisciplinary approach for providing optimal care. Over to you, Marlene.
Thank you very much, Kalli. Thank you, everyone. It's lovely to be here. Yes, as Kalli was saying, I'm going to be talking about managing activities of daily living. So occupational therapy is about enabling people to participate in activities that are meaningful to them. These activities can range from taking care of yourself to working and participating in hobbies, interests, and social events. It can involve offering advice or techniques on how to do something more easily or just more safely. So this session will introduce strategies for managing fatigue, energy conservation, and optimizing independence at home. So what is fatigue? Fatigue can be described as feeling weak, tired, or exhausted. Fatigue is a common side effect of cancer and cancer-related treatment. Cancer-related fatigue is different from general tiredness and not the result of recent physical or mental activity. Some people experience fatigue before, during, or after treatment for cancer. and it can affect people in different ways. Some of the symptoms of fatigue can be having little or no energy, muscle aches and pains, disturbed sleep, mood change, and difficulty performing daily activities such as getting dressed, showering, and preparing meals. Some of the ways to manage fatigue, as Sally has just been explaining to us, are exercise, the importance of exercise, self-care, such as good nutrition, staying hydrated, relaxation techniques, having a support network, so talking to others and accepting offers of help, and energy conservation. And I'm going to talk a little bit more about energy conservation. So when you're feeling unwell, a simple task can feel like hard work. Energy conservation is a means of adapting how you complete your daily activities. There are ways of making small changes to your daily activities that enable you to have more energy throughout the day. Now we talk about 3 P's of energy conservation, and these are plan, prioritise, and pace. In the planning phase, planning the activities is important sort of as you put them in place throughout the day. Think about how you can spread activities throughout the week and include rest breaks. The second P to think about is prioritise. So some activities are necessary, but others may not be. Think to yourself, what do I need to do today? And what do I want to get done today? Begin with the activities that are most important to you. And the third thing to think about is pacing yourself. So can you break your activities into smaller steps or smaller tasks? Plan to have rest breaks between activities and listen to your body and rest before you become exhausted. So applying energy conservation principles to everyday activities, I'm just going to run through 4 examples of day-to-day activities. So I'll just talk about personal care, so showering and dressing, meal preparation, shopping, and laundry. Now with showering and dressing, in the planning phase, if you are feeling tired, there's things that you can put in place just to make it a little bit easier. So in the planning phase, think about where you're storing all your items. So storing items in the same position for daily use can be helpful. Consider whether there's alternatives too, like liquid soap, as it can be easier to lather. Consider equipment options, such as a long-handled sponge, which can just reduce the amount of reaching or bending that you might need to do and allow good ventilation in the bathroom. Prioritise. If you are feeling a little tired, is a daily shower necessary? Or could you shower second daily with a sponge wash in between? And pacing yourself. Consider sitting down to have a shower, sitting down to get dressed. Try a terry toweling bathrobe to pat dry after the shower and allow plenty of time and take rest breaks. The second activity we'll just have a look at is meal preparation. So in the planning phase, think about getting everything ready before you start cooking or before you start preparing the meal. Find recipes with a short preparation time or are easy to prepare, and consider cooking larger amounts and freezing portions so that you can use them on another day if needed. Prioritise, so buy ready-made or frozen meals for days when you may not feel like cooking. And pacing yourself. So spread the preparation time throughout the day. For example, peeling the vegetables in the morning in preparation for cooking in the evening. Or maybe sit down when you're preparing the vegetables, or sit down when you're cooking the food. The third activity we'll look at is shopping. So in the planning phase, consider writing a shopping list with the items listed by aisle. Use a shopping trolley when walking around the shops, and think about shopping at less busy times. Prioritise. Is it necessary to actually attend the shops, or can you do some online shopping with home delivery? And pacing. So if you are doing the shopping, have some rest breaks. Divide the items between the bags to evenly distribute the weight, so you're not carrying everything in one heavy bag. And use a trolley instead of carrying bags if it's available. The fourth area we'll look at is laundry. So in the planning phase, think about what equipment you could use to make it a little bit easier. So for example, use a laundry trolley with wheels rather than carrying the washing. Think about where you're storing everything. So storing items in a central place. For example, the washing powder, the pegs, the clothes horse, in a central location that's easy to get to. And do smaller loads throughout the week rather than one large wash. Prioritise. Consider, is it necessary to actually iron all your clothes? Or could you be getting clothing items that wash and dry without the need for ironing? Pace. Space the task. For example, wash the clothes in the evening and hang out in the morning. This breaks it into smaller tasks and allows for a rest break in between. Another idea is using a clothes horse. So this allows you to sit to hang the clothes rather than having to carry them out and hang them on the clothesline. So equipment can make things a little bit easier to complete daily activities. Examples in showering and dressing. If you are feeling a bit tired, sitting on a shower chair or shower stool and using long-handled equipment can help to conserve energy. Seating. Suitable height seating can make it easier to get in and out of a chair. And domestic tasks, equipment can make these tasks easier around the home. And here's just some examples. So we have a shower chair, shower stool, long-handled equipment such as a long-handled sponge and a long-handled shoehorn. With seating, these are just a couple of examples again. Adjustable height chairs, so you can set them at a height that is easy to get out of. And a power lift chair, which also has an assistor lift function, and it also has the leg elevation. So again, making it a little bit easier to get out of chairs or to elevate your legs when you need to rest. And here's just some common examples of pieces of equipment that might make it easier around the house. So a kitchen trolley, where you can load a few things on the trolley to move it around the house, rather than carrying things back and forth. The laundry trolley, the clothes horse, and a long-handled dustpan and broom. So in summary, fatigue can be a side effect of cancer or cancer-related treatment. When you are fatigued, you may have difficulty performing some of your daily activities, such as getting dressed, showering, or preparing meals. But energy conservation is a means of adapting how you complete your daily activities. The 3 Ps of energy conservation are plan, prioritise, and pace. Use of equipment can make completing daily tasks easier. And consider asking for help from family, friends, or services if you need it. And there's just 3 simple references that can give you some more information as well.
Thank you, Marlene. Thank you very much. There's no questions for you at this time. So I'm going to move straight on to the next speaker, which is Kalli Arthurs, who will be talking to us about palliative care. She's been working, in palliative care for 20 years as an educator and clinician, providing symptom management, supportive care, and quality end-of-life care in various settings. Kelly's current focus is palliative aged care. She's a transitional nurse practitioner for the Palliative Aged Care Supportive Service, or PACS, and works as a link between aged care facilities on the Northern Beaches and the hospitals, ensuring quality end-of-life care for people living in residential aged care facilities. Kelly has an interest in improving end-of-life care, particularly in people with advanced dementia. So over to you, Kelly, and I like your template for your PowerPoint.
Thank you. Thanks so much, Kalli. Thanks for having me here tonight. I'd like to begin by acknowledging that I'm on Guringai country, the land of the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal or Torres Strait Islander people that are joining us online. So there are many things that I enjoy about being a nurse. In particular, being able to work on a daily basis with a dynamic team of health professionals like those that are speaking here tonight. But I also love the opportunity to go to work every day and deliver individualised, person-centred, holistic care to people. And that in turn makes people feel comfortable, and that is very rewarding. So there are many symptoms that people may experience when they're living with a diagnosis of prostate cancer. People may have one symptom, or they may have many. So when they do experience a symptom, it usually or sometimes can have a very big impact on their quality of life if it's not managed appropriately. So tonight I'm going to discuss the most common symptoms that people may experience when they're living with a diagnosis of prostate cancer. So when I first meet people, I usually say my job is basically to make sure that they're as comfortable as possible so that they can live as well as possible. So our main aim in supportive care is to improve quality of life, and to do this, we manage physical symptoms as a whole team. So the main physical symptoms that we manage are outlined on this slide, and they may be problems with pain, appetite, breathing, insomnia, nausea, bowel, mouth and eye care, skin care, plus with prostate cancer, hot flushes, night sweats, and issues with bladder. So just to highlight again that not everyone experiences, all of these symptoms. But if you do, our team can help with them. And I'd also like to take into account when we're looking at interventions for these symptoms, we're looking at the level of distress that each of these symptoms cause when weighing up the benefits of the burdens of any interventions that we might introduce. So when using medication, I'd just like to point out that there's usually no magic bullet or magic solution. Every drug does have side effects, but we do, it's a carefully balancing act of weighing up the symptoms and the burden and how that's impacting your quality of life to determine what we're going to do about it. So Cynthia's outlined pain, so I'm not going to go into too much detail, but what I am going to discuss is what you should do when you are experiencing pain. So most importantly, record it and keep track of it. So that way, that enables us to get a really clear picture of what's been happening for you and what you've been experiencing. For pain, the key things for us to know is where is the site of your pain. And you might have multiple sites of pain, but it's really important to then number those pains and let us know which of the pain sites are causing you causing most problems. Also, the times you get the pain. So that way we can determine if there's any patterns, such as, if you're getting pain mostly at night, or if you're getting it mostly during the morning, when you're waking up and you're a bit stiff. So it's really important for us to see those patterns of pain. Also, it's good to know what the triggers of your pain are. Sometimes just moving a certain way could trigger your pain. And a description of your pain. Is it sharp? Is it shooting? Is it a dull ache? Is it tingling? Does it move? all those things are really important for us to know when we're looking at what we're going to do with pain, because just really importantly, different types of pain usually require different types of treatment, as Cynthia pointed out earlier. Also important for us to know is the intensity of the pain. We use a pain scale, just like the one Sally mentioned with the breathlessness. So it's a 0 to 10 pain. So 0 being no pain at all, 10 being the worst pain you could imagine. And if you do experience that pain, write down, where that pain's sitting. And we actually get a really good understanding of happening for you. So if the pain is new, or the intensity is quite high, like above 6, please don't wait for your next appointment to come and tell us. Please contact your team or your doctor so we can review that straight away. Then we can determine, the best interventions once we get a really clear picture of the pain. And sometimes it's not using medication. For example, using a heat pack, or as Sally mentioned, exercise or passive movements. Or we do use pain medication, like Cynthia pointed out earlier, like sometimes paracetamol is adequate, or sometimes you might need a weak opioid, or you might need a stronger opioid, or you might also need other medications as well. And also radiotherapy can really work wonders in assisting with pain relief. So I've included on this slide an example of a pain diary. I found this on the internet. Your treating team should be able to provide you one. Most engineers over the years that I've cared for them seem to like Excel spreadsheets. So we get really detailed examples of pain. But do whatever suits you to capture what you're experiencing. And if you bring that with you to your appointments, we can go through that together. So it's also important to keep track of other symptoms that you might be experiencing, such as a poor appetite and nausea. And nausea is the feeling of needing to be sick. So the possible causes of a poor appetite and nausea could include changes in metabolism and also medication. And once again, if you experience nausea sometimes or often, just keep a diary of when you experience it and keep track of the triggers that could potentially cause your nausea. Sometimes it might be seeing a large plate of food, certain smells, thinking about food. And that's really important because, like pain, there are different there's different medication for pain relief, such as there's also different medication that we can use for the different types of nausea as well. And then it's good to know if there's any patterns, such as if you've got a poor appetite, what are the patterns? Is it first thing in the morning, you've got a really great appetite and you eat a really great breakfast by lunchtime? Not really, and it's mediocre. And then by dinner time, you've got no appetite at all. That's really good for us to know as well. If you experience nausea occasionally, you might just need to have some medication on hand at home for those times when you do experience it. But if you do experience nausea on a regular basis, you might require regular medication. And also there are non-medication interventions such as relaxation techniques, diversional therapy, like visualization, and just maybe opening up a window, turning on a room fan, or putting a damp cloth at the back of your neck might be enough to assist with your nausea. But very importantly, a poor appetite can lead to weight loss. And if we can't reverse the cause of a poor appetite, then we may recommend hospital-grade supplement drinks or vitamin supplements. So the possible causes of insomnia when you're living with prostate cancer could be lowered testosterone, anxiety, depression, pain, or you might be up multiple times overnight going to the bathroom. Please also record and report it. We, once again, will aim to reverse anything we can reverse. And there may be some non-medication interventions for insomnia, such as, improving your sleep hygiene, creating good sleep habits, or maybe even just drinking less fluids from 4 p.m. in the afternoon. Or there might be medication that you might be prescribed, such as melatonin or other medications. So hot flushes can be very unpleasant. Sorry, into the next one. Sorry, I've just skipped ahead and I'm going back.
You were there. There we go.
I was there, sorry. I think anyway, that's okay. So so we know in the community that 1 in 7 people generally have anxiety and depression. But when you're living with prostate cancer, you might have other contributing factors, such as adjusting to your diagnosis, uncertainty, not being able to do things that you previously enjoyed doing, or pain and insomnia. So it's important to note that we all feel saddled down from time to time, but if that feeling lasts for more than 2 weeks, it's a symptom that you really need to share with your treating team and doctor. Once again, we'll look at the level of distress caused by this symptom to determine the intervention. And we will address anything that we can reverse, such as, once again, pain. And we generally approach anxiety and depression with a multidisciplinary approach with interventions from doctors, but also, social worker and pastoral care as well. So hot flushes can be very unpleasant and can contribute also to insomnia. A possible cause of hot flushes when you're living with prostate cancer is the anti-cancer medication that you're taking. So lower leg swelling is also caused by the anti-cancer medication that you might be taking, but it also could be caused by other illnesses, such as a heart condition, or it could have been caused by surgery, especially if you've had lymph nodes removed. So this symptom can cause discomfort, it can decrease mobility, and it can also impact the health of your skin. Being a nurse, so I was just going to mention, the occupational therapists, they can assist with interventions such as lymphedema, which is massage to help with circulation and decrease that swelling, and also compression stockings. But from a nursing perspective, I'd just like to emphasise that your skin is the largest organ in your body. And if the skin on your lower legs or anywhere else is thin, is maybe frail and dry because you've got swollen legs, and obviously that's contributing to poor skin integrity. It's really important to take good care of your skin, and that might be to not use soap and use a hospital grade, body wash instead, and use moisturizer cream on your legs or any areas of your skin that are dry. This will prevent any potential skin infections or any wounds developing. So it's really important to take good care of your skin. So the last couple of symptoms that I'm just going to quickly discuss are my favourite, and they are my favourite because they are usually those that cause the most distress, but they're the easiest to manage. So like most nurses, I've got a slight obsession with bowels. We would all ideally like to have a moderate bowel motion, and when looking at the slide, it's a type 3 or 4. At a minimum of every 3 days, and that's even if you aren't eating very much, because your body still does produce waste. So the possible causes of constipation are dehydration, decreased mobility, changes to diet. Radiotherapy can cause constipation, but most commonly it can be caused by the pain medications that you're taking, in particular opioids. Your bowel is meant to be constantly moving. If it's moving too fast, that results in diarrhea. If it's moving too slow, that results in constipation. So we just would like it to be moving at a good steady pace all the time. So a couple of things to point out is that fibre such as banana fibre or metamucil or psyllium husk are excellent to assist with keeping your bowels regular, but that's only if you can, drink adequate amounts of water. So if you can't drink lots of water, that can sometimes have the opposite effect and cause constipation. So the fibre supplements are great if you can drink, at least, 1 to 2 litres of water a day. If your bowels haven't opened properly for 2 days, we'd recommend that you have some medication at home to give, to administer if you haven't had your bowels open for 2 days. That way you're getting your bowels moving. And if you get your bowels moving with gentle medication, giving yourself a gentle nudge, that's much better than waiting more days. And the longer you leave it, the worse the problem becomes. And you need to take more medication to get your bowels moving, which can result in very loose motions and sometimes incontinence, which is, awful for anybody. But also after that, people might be a bit adverse to taking any medication again for their bowels, and you get into this cycle of, swinging between constipation and diarrhea, which we don't want. We just want your bowels to be moving at a steady pace and you having those regular bowel motions. So just important to point out also that many people require regular periods of bowel medications daily. Once I said, especially if you're taking pain medication. And many presentations to hospital are actually due to constipation. And constipation can often make other symptoms much worse, such as nausea, poor appetite, pain, and breathlessness. So issues with your bladder. So basically, it could include urinary frequency, which is needing to go to the bathroom often, nocturia or frequency at night, so getting up often to go to the toilet at night, and urinary incontinence when losing control of your bladder, and urinary retention or the difficulties in passing urine. So the possible causes could include an enlarged prostate, or surgery or radiotherapy may have damaged the nerves or muscles that control your urine flow. A physiotherapist, and the question came through earlier about, a physiotherapist can assist with bladder training and pelvic floor exercises, and also some lifestyle changes might help, such as limiting tea, coffee, and alcohol, which can all irritate the bladder. And also, once I said before, limiting fluids after 4 p.m. But medication can also help as well, but that would need to be prescribed. So the possible causes of a dry mouth and dry, scratchy eyes could include medication most often, and also dehydration. For dry eyes, a simple solution is to get lubricating eye drops and pop them in your eyes, 3 to 4 times a day. But for a dry mouth, we recommend that you don't buy any of the commercial mouthwashes or rinses, but because they're often alcohol-based and they can dry your mouth out further. So what we would suggest is you can buy a sodium bicarb mouthwash, either at the pharmacy, much cheaper to buy it at home. You just need to put half a teaspoon of sodium bicarb in a cup of water and rinse your mouth with that. And also you can buy a saliva substitute just to coat the lining of your mouth if you're dry. And you can buy that over the counter at the pharmacy as well. And just using a good, lip balm as well is usually all it takes to help with the dry mouth. But people with a diagnosis of cancer are also at high risk of developing oral thrush. So what you can do is basically whenever you brush your teeth, just have a look at your tongue. And at the first sign of having a coated tongue or sort of a white or furry or coated looking tongue, let your nurse or your doctor know, or you can just go to the pharmacist and let them know that that's the first sign of oral thrush. And once again, if you get some drops, it's like antifungal drops on your tongue, and you put them on your tongue 4 times a day for a couple of days, that should clear that symptom up. If that symptom does become much worse, it's much more difficult to manage then, and you might have lots of other symptoms associated with that oral thrush, which, you know, could include a poor appetite, pain, but also nausea as well. So thank you for listening tonight. Hopefully I've shared with you some useful information. I just wanted to finish with some take-homes. It's highly likely that any symptom you experience, your team has treated before and will have a solution. So please don't suffer in silence. Please share it with us, and hopefully we can help you. If you have a plan to manage a symptom from your treating team and it's not working, there's often many more options available, and there's second, third, fourth line treatment. So just because you've got a solution or a plan in place to address a symptom, that's not it. If it's still troubling you, please let us know. And lastly, if it makes you feel more comfortable, I strongly encourage, when you go to any appointments, to bring with you to your medical appointments a support person, such as a partner, family member, or close friend. Thank you.
Kalli, thank you so much. And I'm glad you're promoting the new booklet from the Cancer Council, which specifically talks to people in the LGBTQI+ community that are living with cancer. So thanks for promoting that. So Kalli, I just wanted to ask you, often people in our group say, there's so many things to coordinate in the hospital and trying to fit it all together. I mean, are there people like you in every hospital that can help coordinate care for a single patient, bringing it all together?
Yeah, so I've been a community nurse. I've also been a palliative care nurse doing in-reach into various hospitals throughout Northern Sydney. So basically, people just need to ask their treating team. Don't sort of make the assumption that the team will automatically refer you on to palliative and supportive care. You just need to ask, and your team will refer on. Most hospitals, definitely in metropolitan areas, have palliative care teams in each of the hospital. But if there's not one in the hospital, there will be a community palliative care team. So that hospital team will be able to refer on to the community team after you've gone home.
So you mentioned mostly metropolitan areas. Does it exist? Are there services in rural areas as well? Because some of our listeners are in remote areas.
There definitely is. It varies. Even in Sydney, where I'm based, every area it looks different. The team looks different, but there's definitely a palliative and supportive care team in every area. Just need to ask either your GP or the treating team in the hospital or oncologist, and they'll be able to link through to the community team. And whether it's, depending on how rural and remote you are, it might be one day a week there is a clinic available, or there might be telehealth available as well. But there's definitely support for everybody. You just need to ask.
That's great. There's a question here. I'm not sure if you can answer it, and if you can't, that's fine. I can. It's regarding the testosterone changes and insomnia that you mentioned. Do you know the reasons why they linked?
I think Kalli, you or maybe Cynthia may be best placed to answer that question.
I can answer it. I wanted to give you the opportunity, of course, first. So because many patients, as we know, prostate cancer growth is dependent on high levels of testosterone. One of the treatments for advanced prostate cancer is, of course, to reduce or depress testosterone levels in the body. And of course, all our hormones in our body are closely linked, and there's a lot of feedback mechanisms. So things go down, other things go up. So that's exactly what happens as we suppress the testosterone levels to treat the prostate cancer. Cortisol in the blood goes up, and cortisol, as we know, is a stress hormone. So it makes us feel, as we all know, like those of us that are speaking now, we're on the edge. we're alert, we're hyper alert, and so that's what happens to these patients. They've got high levels of cortisol, and that keeps them up at night and contributes to their insomnia. So I hope that answers the question in the audience. I'm aware we have 2 more speakers, so we're going to move on. Thanks again, Kelly, and moving on to our next speaker, who is Sarah Jane, and she is the Acting Deputy Director of Social Work at Hornsby Hospital, having worked in Northern Sydney Local Health District since 2005. Her experiences with acute medical patients across various ages and illnesses, including the provision of supportive counselling to those receiving a new diagnosis of cancer and other life-limiting illnesses. Sarah Jane is most passionate about leadership, specifically caring for her social work team as they provide social work support and complex interventions to patients negotiating hospital admissions and discharges. She has extensive experience with people diagnosed with dementia and their carers as well as personal experience of someone in her family treated with prostate cancer. So over to you, Sarah.
Thank you very much. I'm so privileged to be here with you guys tonight. We've heard so much wonderful information so far from my colleagues. And I don't know about you, but I just feel like I've learned so much already. So I hope that we can continue that with my little conversation with you now. So I suppose I'd like to just shed light on what social workers do as part of the palliative and supportive care team. And social work as a profession, most people think of us as the ones who will send your relative to a nursing home. But in the hospital, we actually see ourselves as people who focus on empowerment and informed choice, advocacy and self-determination for our clients in the hospital and helping them to navigate the hospital system. So before, when there was that question about who in the hospital kind of helps to direct those things, social workers are part of that team that will be identifying problems that people are having and helping them to link within the hospital team and within the palliative care team with those specialist nursing staff or palliative care staff or people who are in the community to basically put them in the right track. We like to think of ourselves as kind of crowd controllers in that way sometimes. So, I mean, advocacy and self-determination are never as important as when somebody's facing a life-limiting diagnosis, potentially life-limiting, and a really notoriously challenging treatment regimen. So today I'm just going to talk about a few things. So you can see what I've got on the agenda here. Introduction. I'm going to talk about just epiphanies generally, relationships and how people need to foster those and some of the difficulties that they can have in their relationships as a result of a cancer diagnosis and the treatment and everything that goes with that. Some decisions that need to be made and ways of making sure that your decisions are made in the way that you would like. And also just a bit of a brief touch on services that can assist, and certainly we've heard a lot about services already that can provide support and assistance for people who have cancer diagnoses. I was really impressed to see that LGBTI booklet from the Cancer Council. That's great. Good to know it's there. All right, I'm going to make, yes, it's working. All right. So what I would just like to talk about firstly is, in my years of experience working with people in the hospital across various different medical specialties, I haven't ever been a palliative care specialist, as all of the other clinicians that are talking to you guys here tonight are, but I've worked very closely with palliative care team within the hospital and providing assistance around the, I suppose, making sure that everybody is involved and empowered in that process of understanding what the palliative care service does and providing emotional support and counselling during that stay. So as part of that process, it's been my experience that oftentimes people come to a diagnosis of cancer or stroke or heart attack, and I'm specifically using those medical problems because often they're things that people can have a really dramatic diagnosis, but then with live long lives afterwards. So for example, with prostate cancer, which people most often live with rather than die from, given the right survivorship and changes that they can make to their life and their sort of lifestyles. And so as part of that process, there's often an epiphany or an awakening of some sort, which can help people to just, I suppose, become more clear about what's important to them in their lives. There are some common themes. Now, I was going to do something fun, like suggest that someone raises their hand and tells a story, but I realize that there's probably too many people here and we're a very long presentation. So I dare say, if you can, while I'm talking, stand up, jump around, keep yourselves awake, and we've got a little bit more to go. But common themes that come across in these epiphanies are where people suddenly realize that the ones who are ostensibly their support people actually aren't emotionally there for them, or that they can't provide for their support needs while they're having their cancer treatment. They might find it about themselves rather than about the person that they're meaning to support. Look, others will find new faith or solidify perhaps a latent faith or develop new spiritualism as part of this journey where they've had to face kind of their own death, really. And others do like the midlife crisis style thing where they might, you know, decide that suddenly they need a Lexus when really they were just driving a Toyota Corolla from 1998. Other things such as having a sea change or a tree change, making big decisions about their lives because they suddenly realize that actually how I was spending my life and what I was doing is no longer important to me, or I realized that I've been barking up a tree that was somebody else's expectation for my life and not something that was actually fulfilling me myself. I suppose the benefit of talking about this in this context is to understand that when a person has a new diagnosis of cancer or some other serious life-threatening illness, there's a shock element that happens. And so you can be very much feeling like this is the road that I need to travel on now, but actually having some time just to stop and think, discuss your thoughts and your big changes and maybe the sale of your house or your car with your partner or other people whose opinions you trust is really helpful before you make any kind of life-altering, you know, can't turn back style decisions. Alrighty, so for my next slide, I wanted to talk about relationships. Now, I would just like to say this lovely gentleman here in this picture was just part of the stock images that I found when I was looking for ways to populate this PowerPoint, but he's very well placed in here. So everybody has a unique experience of family. Even among nuclear hetero families, there are toxic relationships, domestic violence, abuse and coercion, problems with communication, financial struggles. You know, and there are some nice parts, don't get me wrong, respect and healthy communication, financial security and values that align. But let's be honest, the nice parts can tend to be less common than the nasty parts, I think, particularly when we're all busy and we might be missing each other and not connecting properly. People are wonderful, but quite messy. So I wanted to touch on these parts of relationships. So we are very social beings. Research into bonds created with babies tell us that we actually can't thrive without social connection. However, for a number of reasons, social isolation can occur. Now, I'm imagining that I might be speaking to an audience who've experienced some serious loss of relationships and I suppose disconnection from people who are close to them as a result of coming out, you know, loved ones being unable to accept that the person they thought they knew actually felt like they were different on the inside, or that perhaps they were no longer willing to conform to a social or cultural norm because that's what was expected of them. So this has the potential, and I'm generalizing here, but it has the potential to leave people without, I suppose, long-term relationships and perhaps leave a focus on romantic relationships that may not be as stable as is required for, you know, focus helping out with a cancer diagnosis and where the increased practical and emotional support needs exist. So cancer also dramatically changes and just interferes with our relationships. People become carers and patients rather than equal partners who take equal part in the roles of the family. equal household shares. And of course, it impacts connection in the way that when your mental health is affected, if you've got anxiety or depression and you're trying to function through the haze of just getting through the day, then it's very hard to then make quality connections with the people around you. And therefore you can have supportive people in your crew, but you can't really connect with them. Particularly with prostate cancer, changes with anatomy and hormones, with, as it's been discussed earlier, maintaining healthy sexual function, or even in fact, an interest in sexual function at all, and the loss of masculinity will of course be having a huge impact. And I can only imagine if there are any transgender women with us here tonight, the impact that a prostate cancer diagnosis could then have on their kind of emotional well-being and their identity in that time. So there are lots of reasons why we can't do cancer diagnosis and treatment alone. So my recommendation is that please don't try. Please seek support in whatever way is best for you. For some, that's just the people you've got around you. You might have really strong family or friend connections. For others, it's going to a psychologist and having 20 kind of bulk build sessions, and that's what's needed. There are also really wonderful supports available through the Cancer Council website, and I've got a link for that later, which I'll show you. And also PCFA have, that's the Prostate Cancer Foundation of Australia, have an excellent service there that's that involves specialised counselling, and there's the nursing support there. So I would recommend anybody go and have a look at those websites if you haven't already. The Carer Gateway is also a really excellent resource for carers. So if you do find yourself in a carer role with somebody who is being treated for cancer, Carer Gateway can provide support groups. There are also finances available for carer support services for emergency care. All right, next slide. Now, this little section is called decisions. So we've heard a lot already about the decisions that might need to be made, about the multidisciplinary team and how that would ideally will be working to everybody's best outcome. But I suppose not everybody's quality of life looks the same. It tends to be a buzz phrase in the health system. And I'm sure you've all heard it, aside from tonight, you know, what is quality of life? Is quality of life a long life? Is quality of life a full life? To different people, it means a number of different things. So your epiphany or your awakening experience at the diagnosis time will certainly inform what your quality of life looks like, but also all of the experiences that you've had that have worked you up to this point. So how can you ensure, I suppose, that your quality of life is the version that is activated if you should lose capacity? So like has been spoken about before, if you're unable to make decisions for yourself, how do you make sure that that's going to be the right decision and it's going to maximize your quality of life the way you would like it? The good news is this, as well as with the Advanced Care Directive that Cynthia spoke about before, and she spoke in great detail about that, so I can skip over that slide a bit. You actually do have the capacity to ensure that decisions can be made in your best interest and with your quality of life in mind. So at the beginning, you will make your own decisions. A person who has capacity, who is able to discuss benefits and side effects and risks and all of those things that a doctor will present as part of your treatment plan, they can make their own decisions, often using the support of your family and friends, so that you find if there are things that aren't able to be understood, you've got support, you've got somebody who can bounce ideas off you, or can maybe just ask the doctor to phrase something in a way that you may understand better. You can tell I've worked a lot with dementia, because certainly people have different levels of understanding. We call that health literacy in the health business, but what it means is, somebody can have an IQ of 130 but not understand a single thing about symptom control, or not know the acronyms when it comes to your cancer diagnosis. And if a doctor isn't able to hear that you need to know that in a different way, then they will assume that you understand. Anyway, moving on. For the people who aren't able to make their own decisions for whatever reason, so this is because of a cognitive incapacity, and that can be to do with a mental illness or a stroke or a dementia. Sometimes it can be temporary, where if there's an infection and a person has become delirious or acutely confused for a period, they may need somebody to make decisions on their behalf and then come out of that. For others, this could be something that continues on. So firstly, the Guardianship Act 1987, Section 33A, it describes a person responsible hierarchy. So these people are able to make decisions of a medical, dental, accommodation kind of nature for you if you can't. So the first one is a guardian. Now, this is a legally appointed person, a guardian or an enduring guardian who has been given the right to consent to medical and dental treatments for you. Now, if you don't have a guardian, then number 2 kicks in. And so that's a spouse, a de facto partner, and that includes a same-sex partner where there is a close and continuing relationship. Or if you don't have a spouse or a partner, then the third option is a carer. So this is an unpaid carer who provides or arranges for domestic support on a regular basis. So we're not talking about your cleaner that comes in every fortnight and cleans your floor for you. We're talking about somebody who comes in because they care about you and they're providing assistance to you on a regular basis. Now, if there's no carer or the others, then a friend or relative who has a close personal relationship, frequent personal contact, and a personal interest in the person's welfare on an unpaid basis is number 4 in that person responsible hierarchy. So it's important to recognise that number 4 is actually the son or the daughter in this picture, or your next door neighbour who you've had a lot of contact with over the years. Because if you don't have a guardian or a spouse or a partner or somebody that's coming in to see you regularly to provide assistance, then that's where that number 4 person comes in. So it's worthwhile thinking about who that might be and who your next of kin will be if you're going to the hospital. Anyway, let's talk more about how we get those things. So that number 1 was a guardian appointed. So at the solicitor, or under certain circumstances, not at a solicitor, but I won't go into all of the detail about that. Yes, then I will. So the enduring guardian and the enduring power of attorney can all be made at the solicitor, chosen by the person needing a substitute decision maker when they have the capacity to do so. It's the same with power of attorney. When you have the capacity to do so, you can make that appointment. So a guardian looks after decisions about medical and dental and accommodation needs, whereas a power of attorney only looks after financial. Now, you can have a look at that rest assured link there, which you can't just click and see the link. But if you Google that, the State Library of New South Wales has an excellent resource on enduring powers of attorney and enduring guardians and all of the other things that go along with that. All right, so as I said, Cynthia talked about this. I just wanted to point out that Advanced Care Planning Australia also have an excellent resource for the LGBTIQ+ community. All right, so these last 3 slides are just about support and services. So we've got Prostate Cancer Foundation of Australia, which you guys, I hope, have seen that website. So they've got wonderful support group options, specialist nurses and telehealth nursing, and there's so much disease and research info on there. In researching to do this webinar with you guys tonight, I had a look and I was amazed at the wonderful research and the support and just the excellent, I suppose, promotion of quality of life and survivorship that was on the PCFA website was really great to see. The next slide that I've got here is for my aged care. Now, for people who are over 65 and maybe living with a cancer diagnosis and having palliative care treatment, then you are able to access my aged care for all things. So it can be as simple as needing a cleaner all the way up to residential aged care facility permanent placement. So everything government subsidised that comes under the aged care heading is able to be accessed through the My Aged Care portal. Now, it's just worth noting that it does take time to get approval. So from the moment you make the phone call, if you're just looking for a cleaner, it could be 8 to 12 weeks before you even have an assessment. And if you're able to access a service, because there are services available in your area, for an urgent nursing home placement, it might take you only a couple of days because they'll prioritise based on their triage system. So state your urgency. And then the last one that I've just popped on here is the Cancer Council, because they also do provide some assistance with the costs of things. So transport bills and accommodation, where eligible, people can claim some costs back. And they've got so much information about most of the cancers, and also they've got support group information as well, which, as I would hope, if you are suffering with a loss of kind of socialization and you're feeling a need to connect with other people who do have either prostate cancer or other forms of cancer, and you may not be in a place where you can access the PCFA, likely the Cancer Council would have some support groups in your area. Now, this last slide I've just got on is just my way of saying, if there's anything that's piqued your interest today, or if there's something that you're kind of thinking on or starting to chew over, I would just ask that rather than sitting on that maybe take the next step while you're thinking about this, because it's really easy just to plop back into our routine way of doing things. But I would hope that this information has been helpful for you tonight, and I encourage you to make connections and go on living your best lives.
Sarah Jane, thank you so much. Such important information, and sorry we had to rush you at the end. I'm going to hand straight over to Steve Calder, who was a pastoral care coordinator at Hammond Care since 2014, and now is the general manager at Hammond Care since 2021, and he'll be talking to us about spiritual care. Hang in there, everyone. It's just 5 more minutes, and that will conclude our session. Thanks. Over to you, Steve.
Yeah, thanks, Kalli. Thank you, everyone, for having me tonight. What's, I hope, really, really clear is that we're talking about palliative care and supportive care. It's all about meeting a really wide variety of needs for the person who has a potentially life-limiting illness. And one of the needs I would argue passionately is just as important are the spiritual and emotional needs. In other words, I'm saying that that spiritual care is a part of supportive care. Now, I need to explain what I mean by the word spiritual, because that can be a bit of a put-off for some people when they say the word spiritual. Let me tell you what I don't mean when I use the word spiritual. I don't necessarily mean religious, though for some people their spirituality is all about their religion or their faith. And spirituality doesn't necessarily mean Eastern mysticism, though again, for some people, Eastern mysticism isn't an expression of their spirituality. Rather, spirituality is kind of basically the word that people in the health sector use to acknowledge that not every part of life can be measured with a stethoscope or looked at under a microscope. So it sort of assumes that that kind of spiritual, that we're sort of more than biology. So spirituality is the word that sort of covers things like different kinds of meaning that people associate with their life, the sense of purpose and hope and values and desires and passions and loves that really is common to everybody. It refers to the feeling of connectedness to people and places and possibly the past and the present and the future, and possibly something bigger than themselves, and the desires to make sense of the world around us and why events happen. And so note that by this definition, both religious people and non-religious people have a spirituality. You don't have to be religious to want to find meaning in life when you have cancer. And so when it comes to having a serious or life-limiting illness, these issues can be heightened. So some of the questions that people face in that situation key into these kind of spiritual issues. Questions like, have I lived my life well? Do I have any unfinished business that I need to sort of address? Do I still matter now that I have cancer and maybe am coming towards the end of my life? What will my legacy be when I die? How will those I love cope when I'm gone? So there's lots of questions that sort of are heightened when it comes to living with a life, living the illness. And the point is, when life is going well, many people don't really spend a great deal of time thinking about these things, but experience a trial or a trouble, like a serious illness, and all of a sudden some of those questions and issues can come to the surface with real force and real urgency. And when you have the courage to face some of those questions, or maybe you have no choice but to face those questions, the answers to those questions can be experienced as what you might call spiritual distress. And so again, sort of addressing those questions and raising those issues can be something that's very important to do. Now, if you're lucky enough to be an inpatient in a palliative or supportive care unit, there's a good chance someone might actually help you unpack some of those things for you. Now, I realize what I just said there. I said, if you're lucky to be in a palliative care unit, and I realize that many people think I must have drawn the short straw if I need to go to a palliative care unit. But having worked in a palliative care unit, I know that the teams who work there are super experienced, kind, professional, non-judgmental, and have a really holistic way of caring for each patient. So please don't be afraid or worried about going to a palliative care unit if that's what you need to do. And indeed, some, not all, palliative care units will have a pastoral care coordinator or a spiritual care coordinator who may be able to help you address some of these important issues. If you don't have access to a palliative care unit or a spiritual care practitioner, maybe you're living with a partner or living by yourself, maybe receiving supportive care in the community. One of the ways to assess your own spiritual needs and spiritual distress is to ask yourself some good questions, like these ones, or like one like this. When life has been difficult in the past, who or what has helped me to cope? So that is a good question to ask yourself. If you're going through a difficult time, and we've all been through difficult seasons of our lives, who's helped me to cope in the past? Or what has helped me to cope in the past? Because that's a good way to kind of think, well, that might be a good place to go to for help in the present. And what do I need to those who care for me to know about me that will help them to give me the best care possible? I think that's a really good question. What do people need to know about me that will help them to give me the best care possible? And I think that's a really important question. And can I ask you to be honest when you answer, when you ask those questions, or when you answer those questions? There's no shame to say, I have spiritual needs, I have emotional needs, I have physical needs. Everybody has those kinds of needs. You don't have to be sick to have those kind of needs, but they are heightened in all of those things. So, so be honest about those things. I wanted to talk about spiritual distress in terms of losses and burdens. People do experience enormous, really great variety of spiritual distresses in terms of losses. Those things can really impact your spiritual well-being. And of course, then there's losses, but there's also burdens on the flip side: fear and anxiety and frustration, boredom, sadness, anger, regrets, and so on and so forth. And again, so although it can be very painful to confront some of those losses and burdens, ultimately, one of the goals of spiritual care is to being relieved of those things, to have someone to talk to about that. So perhaps if I can just quickly conclude by saying, when you think about spiritual care and about getting help, be realistic and honest about your own spiritual needs. There's no point in saying, I'm okay, if you're not okay. We've also heard before tonight about looking for the support of caring friends. I think that's really important. Don't do this alone. Surround yourself with people who are going to love you and care for you. And if people say to you, oh, it's going to be okay, or you'll get over this, gently remind them that the best way for them to help you, to support you, is just to listen to you, listen to your concerns without trying to make you feel better. That's what great spiritual care actually sort of begins and ends with. It's just listening really carefully, making space for people to do that. And if you can be, if you can have someone in your life who's going to do that, you'll get great spiritual care. And again, obviously finding supportive networks and groups in your area. And because we come from a wide variety of places, it's important to kind of acknowledge that that'll be different for each person. I will finish with one last thing, and that is, I love this idea that comes from Ira Byock, who wrote a book called The 4 Things That Matter Most. Ira Byock was a palliative care physician, and you might think that, you know, what are the 4 things that matter most to a doctor? Maybe it's bowels or morphine or you know, whatever it might be. He says the 4 things that matter most are to say and hear, please forgive me, I forgive you, I love you, and thank you, which I think is really profound, and I think really goes to a lot of the spiritual issues that people have. Not easy to do, by the way. He doesn't say it's easy to say or hear those things, but actually they're super, super important. And I encourage you to there's a book that you could look out for in Amazon, worth a read. Thank you.
Steve, thank you so much. And thank you everyone for this great conversation. And thank you for looking after our community. Thanks for dedicating your time. You've had long, busy days. You're doing this for free out of the goodness of your heart. And we really appreciate each and every one of you sharing your expertise with us. There's no time, unfortunately, for Q&As. I just wanted to say tonight's session has been recorded. So there are people that weren't able to watch. We will share the recording with you. And I just wanted to round out by one comment, though, that did come through. Thank you for this session tonight. As I'm just on the start of my journey, I have some notes that I did not even think about. So there we go. So even at the beginning of the journey, you know, we've given him something, some food for thought. So thank you, everyone. I think it's a job well done. I'm going to hand over to Gary to conclude the session.
Thanks so much indeed, Kalli. I'd like to join Kalli in thanking all of our speakers. This has been a real passion of ours, this first webinar, to be able to really try and demystify palliative care. And you're quite right, Cynthia, when you made the statement that people have a certain vision of what palliative care is, and it is about end of life, and it's so much more now than what it was in its early days. Again, thank you very much. To all those support group leaders that are watching, I've received many emails for our previous webinars that we've conducted, asking permission to show the webinars during their support group sessions. Now, we have a YouTube channel. This particular webinar will be going up on that. All of our webinars, our past webinars, are on that YouTube channel. You can use them freely. And this is a perfect webinar to be able to run a support group session on, because you've got each speaker, you can present, stop, hold discussion, and then continue on through the webinar. So this has just been absolutely fantastic tonight, and I want to thank everyone very much indeed. Just to wrap up quickly, our next webinar is going to be on the 26th of July, and it's an update on urination troubles, incontinence, and erectile problems after surgery. Now, we had this one last year. We had such an amazing response, and on our YouTube channel, there's been over 600 odd hits on this from around the world looking at that webinar. So this is an update. We very much would love you to be part of that. All of those that are registered, you'll just get reminder emails from our organisation that's hosting our webinar series, Logic Connect. So until next time, thank you very much for your attention. It's been a long session, but just the most informative I think we've had in a long time. Good evening to all.